Hello, this is Dr. Molly Faulkner. I'm a nurse practitioner and a clinical social worker at the UNM Department of Psychiatry, Division of Community Behavioral Health. Today, I'm going to be presenting this lecture to the new students in the College of Nursing. This is going to be talking about screening, brief intervention, and referral to treatment. This lecture is made possible by a grant through SAMHSA. This is the Rural Urban Health Professions Student Screening, Brief Intervention, and Referral to Treatment Training Grant. We are training students in nursing, social work, psychology, and psychiatry at the Western New Mexico University, Central New Mexico Community College, the University of New Mexico, Eastern New Mexico University, and New Mexico Highlands University. This is a 3-year grant, and we are in about a year and a half of that grant. This is the team of trainers, coordinators, and evaluators that works with me. We have nothing to disclose, no financial obligations, and you can read the acknowledgments here. We're going to be talking today, giving you an overview of screening, brief intervention, and referral to treatment in primary care. One critical aspect of this model is motivational interviewing. We will be touching on it in this lecture today, but it will be not a large part of the lecture itself. The objectives for this training today are for you to increase your understanding of the SBIRT model and its efficacy in screening for risky substance use in primary care. We'd like you to be able to know how to describe the public health impact of substance use in the patient population of New Mexico, for you to broaden your knowledge, skills, and perceptions related to working with substance-using patients in primary care, and to identify substance use screens used in primary care settings. The goal of SBIRT, the primary goal, is to identify and effectively intervene with those who are risky or at high risk for psychosocial or healthcare problems related to their substance use. This is truly a public health model of primary prevention to try to catch people long before they develop substance use disorders. SBIRT is really, in its best sense, a comprehensive, integrated, evidence-based approach and model to the delivery of early intervention and treatment services for individuals who have substance use problems or who are at risk for them. SBIRT has been a model of care since the 90s, but really put into placement in the early 2000s. And there are many grants that have been conducted, and we are one of 13 grants that was awarded in 2016. So there are many grants around the country that work with different universities and health profession students. So SBIRT stands for screening, where you promptly identify a patient who needs further assessment for their unhealthy levels of drinking or drug use. A brief intervention, where you increase the patient's awareness of unhealthy use, and it enhances their motivation to change. This is where you use primarily the motivational interviewing techniques we speak about. And referral to treatment that assists ready patients with an action plan for change. And that action plan can be either behavioral, pharmacologic, or a referral to specialized care, or some combination for this. So what is SBIRT and why do we use it? This is a video made by ADEPT at the University of Missouri. They received a grant very similar to ours many years ago, and they created this wonderful video to explain to you all the reasons why SBIRT is critical to implement in primary care and other settings.
We all know alcohol and substance abuse is a problem that affects more than just the users. When you consider the number of people affected, changing those numbers might seem insurmountable, but it's not. As healthcare providers, we are perfectly positioned to do something about it. That's why we all need to be adept at identifying and addressing alcohol and drug problems. Wait, Aren't these things somebody else's problems? Furthermore, why should we care? First, we should care because alcohol and drug problems are common. Studies have shown the prevalence of substance misuse is higher than what we're currently addressing. Our primary focus here is the 20% of people who are at-risk users. These users include the 1 out of 6 patients you see that has had at least one episode of binge drinking in the past 30 days. 1 out of 12 patients meets the standard diagnostic criteria for an alcohol use disorder, and 1 out of 50 meets those diagnostic criteria for a current drug use disorder, including illicit and prescription drugs. Oh, but I don't have any of those people in my practice. Think again. We all see patients who have these problems, even though the problems are often hidden. Why should we care? Because alcohol and drug problems are serious. Alcohol and drug problems cause or complicate a lot of chronic diseases and acute problems. Half of all trauma center visits are alcohol related. And substance misuse increases an individual's risk of several chronic diseases. Chances are you're already treating these people. Furthermore, alcohol consumption results in over 100,000 deaths each year in the U.S. and ranks third in preventable deaths, following tobacco and poor diet and inactivity. Why should we care? Because alcohol and drug problems are also expensive. Substance abuse is a problem that everybody pays for. Federal and state governments spend at least $373 billion a year on substance abuse. That's $1,486 per person in the U.S. Furthermore, of the total substance-related spending, less than 2% is spent on prevention and treatment, while almost 96% is spent on the collateral damage from alcohol and drug abuse. Shoveling up this wreckage puts a huge strain on the budgets of much-needed programs, including government-funded healthcare, which must cover most of the burden. This cost is funded by your tax dollars. Okay, so these problems are common, serious, and expensive. So what? There's nothing I can do about them anyway, right? Actually wrong. There are things you and I can do that make a difference. With adept training, small conversations result in big impacts. An important part of ADEPT is SBIRT, a proven method for addressing substance misuse in routine medical care. SBIRT stands for Screening, Brief Intervention, Referral, and Treatment. The main focus of ADEPT training is screening and brief intervention. The first and most important step is screening for risky behavior. A person doesn't have to be addicted to be in a risky category, and any use of tobacco, illicit drugs, or prescription drug misuse is considered risky. Solid population-based evidence sets low-risk drinking limits for men at no more than 4 drinks in a day and no more than 14 in a week. For women and for men over 65, low-risk limits are no more than 3 drinks in a day and no more than 7 in a week. A lot of people are surprised at how low these limits are, but the science is solid. Anything more than these limits is a positive screen. And with a positive screen, it's time for a brief intervention using motivational interviewing techniques we'll learn later in the ADEPT training. But that conversation would just be too uncomfortable. My patients would just lie. They'll think I'm accusing them. But the vast majority of patients say, my doctor should feel free to ask me how much alcohol I drink. If my doctor asked, I'd give an honest answer. If my use affects my health, my doctor should advise me. Moreover, there's good evidence from many randomized clinical trials that if we just talked with the risky user about cutting down or quitting, 20 to 30% will do it. These conversations also reduce the risk of another ER visit for trauma. As you've seen, most of the time and energy put into substance misuse is responsive, reacting to the physical, social, and economic consequences. Adept is changing all that. Instead of cleaning up the wreckage, we're getting in front of the train and steering it along a safer route. Learning a few simple skills can make these conversations quick and comfortable for you, and more importantly, helpful for the patient. The next few videos in our training will help you learn these key skills. Visit our website to take the next step in this training program.
I would encourage you to write this down. adept.missouri.edu has some great additional videos that you could use to enhance or further explore SBIRT in the clinical setting. I'm going to talk a moment about epidemiology of substance misuse in New Mexico. We know that nationally, we've had the highest alcohol-related death rate for the past 30 years. That is hard to imagine. In the last decade, New Mexico has either been number 1 or number 2 in the nation for drug overdose death rates. For ages 12 to 17, we've been among the highest rates nationally in the past month for illicit drug use, in the past year for marijuana use, and in the past year for cocaine use. The epidemiology of binge drinking in New Mexico. I thought I'd start out with telling you what the binge drinking definition actually is. In the previous videos, they were saying that 4 or more drinks on a single occasion for men is considered binge drinking. 4 or more. Excuse me, 4 plus. So we're just talking about 5 or more drinks on a single occasion for men, and 4 or more drinks on a single occasion for women. Underage drinkers consume more drinks per drinking occasion than actually adult age drinkers. That's why it's so important that you assess those underage drinkers as well. And this is a self-report that males say that they binge drink more than females, and self-report more Hispanic males say they drink more than other ethnicities. These are all self-reported. The public health impact of alcohol and drugs and tobacco on New Mexicans is evident. 8 of the leading 10 leading causes of death in New Mexico are at least partially caused by abuse of alcohol, which is absolutely 2 times the national rate, other drugs, or tobacco. As you can see under alcohol, we have heart disease, malignant neoplasms, cerebrovascular disease, chronic liver disease, and unintentional injuries and suicide. And in New Mexico, we have 1.7 the national rate of unintentional injuries due to alcohol consumption. This is really kind of a rethinking of substance use problems from a public health perspective. We know that there are far more at-risk and binge drinkers in our population than there are dependent users. Therefore, this model really tries to seek out and intervene early with the at-risk and binge drinkers, which again are far more in number than we have dependent users. So we can prevent them from becoming a dependent user. So it's far easier to engage and much easier to treat with education and a brief negotiated interview prior to developing associated health issues that accompany dependent or heavy use. This is a slide that just points out the medical and psychiatric harm of risky drinking. I love it because as a nurse and nurse practitioner myself, I like to have tools with which I can share with my patients to show them what I'm talking about. And this is a very self-evident handout. I'm not going to read you all these issues, but we know that high-risk drinking, the effects on the body can include premature aging, inflammation of the pancreas, ulcers, liver damage, and many, many more things. Nearly all symptoms of the body can be adversely affected by risky or dependent levels of use. SBIRT is really a highly flexible intervention. This is a slide that shows us where SBIRT has been used across the country and in different settings. One of the settings that people don't think much about is in your OBGYN or pregnancy setting where these women are screened for risky drinking. You may be in the emergency room. Here at the University of New Mexico, we have had expert providers in the emergency room because they have such a high risk of their patients having substance use issues. You could use these in school-based health clinics, veteran centers, homeless facilities, etc. It's very flexible and has been effectively implemented in a range of these settings. This is also a slide pointing to all of the health sciences center across the country and medical specialty areas where SBIRT has been used. We see Baylor, University of Missouri, UCSF, Yale, and you can see it's been used in pediatrics, family practice, internal med, psychiatry, emergency department, and even in surgery before people go in for surgery. They're asked about their substance use. It is important to know that SBIRT is really not looking for addiction. Yes, you might find it, but it's not looking for addiction. It is looking for individuals who are at risk in their use of alcohol and other drugs. It's specifically seen to find and help individuals who are not seeking help for addiction, and therefore is termed an opportunistic intervention. And I know you're familiar with this if you're doing primary care. It's important to be able to evaluate and screen for issues when you have these patients in your office. This is a model of the percentage of patients who have risky drinking versus those who have substance use disorder. Again, more people at the lower overall risk than the abuse or dependent drinkers. And as consumption increases, so do the consequences of that drinking. We know that greater than 50% of health consequences of alcohol occur at the risky use level, such as injury, cancers, accidents, liver disease. So these are some of the many terms you will encounter in the world of addiction medicine. This pyramid is meant to illustrate the spectrum of use. As you approach the top, both consumption and consequences increase. For any given substance, some number of people are abstinent users, some are using it in a safe and sustainable way, some are using it in a risky and possibly harmful way. And since 2013, with the DSM-5 changes, diagnostic criteria has shifted from dependence or addiction substance use and addiction to criteria for substance use disorder, with severity indicators of mild, moderate, and severe as qualifies for the substance use disorder. This is really the prevention paradox, that we must address the risky drinking at the low level to prevent it from creating the person from developing a more risky or substance use disorder. We also know that the highest rate for success of treatment is at this risky level. This is the severe and dependent, risky, harmful, low risk, or abstinent. So why is SBIRT important for nurse practitioners in primary care? Why am I talking to you? Well, there are 922.6 million physician visits per year, and 56.2% of those visits are made to primary care physicians. In 2010, the primary care workforce in the United States included 209,000 primary care physicians, 56,000 nurse practitioners, and 30,000 PAs. Here in New Mexico, in 2015, the primary care workforce included 2,075 primary care physicians, 607 nurse practitioners, and 278 PAs. This is why I'm talking to you. I see that every provider is an addictions provider. I certainly did not see myself as an addictions provider when I went to nursing. But the fact of the matter is, you're going to see these patients in your primary care offices. So you must learn effective ways to screen and intervene with these clients. Primary care providers are really in key positions to screen, intervene, and provide education about substance use. The best evidence for efficacy is in primary care for this model, where screening is done by the patient's clinician, in a context that the patient knows and visits longitudinally for the preventative and comprehensive care. I'm going to switch a little bit. I want you to imagine somebody for whom alcohol is a problem. This might be a patient, could be somebody you know, could be somebody in your family. When you hear the words alcoholic or drug addict, what are the first responses that come to your mind? Are these the pictures that you have in your mind? Somebody who's an alcoholic or a drug addict? Or is this somebody that you might see as an alcoholic? We know that alcohol and prescription drug abuse in adults 60 plus is one of the fastest growing health problems, and that elderly people are at high risk of developing opioid addiction. In the United States, 2.5 million older adults have alcohol problems, and adults age 65 plus consume more prescribed and over-the-counter meds than any other age group. Or could this be a drug addict? A young man such as this, who might be a neighbor or a friend of your daughter or son's. On an average day during the past year, an average of over 5,000 adolescents used prescription pain relievers non-medically for the first time. And we know that prescription drugs are the second most abused after marijuana in adolescents. Just briefly, substance use disorders versus primary care illnesses. They are currently among the 10 leading preventable risk factors for years of life, loss to death, and disability. Approximately 20% of patients seen in family practice actually have substance use disorders. And despite the high incidence, substance misuse was diagnosed in only 9% of general and family practice visits, 8% of internal med visits, and 5.1% of psychiatric visits. We are not evaluating, nor are we documenting or treating substance use disorders effectively. Relapse rates. I wanted to speak to you briefly that relapse rates are common and similar for drug addiction as well as other chronic illnesses. In this slide, you see the percentage of patients who relapse is on the left, and across the bottom, you see the different types of issues regarding the type of relapse. We have drug addiction, which is 40 to 60% of patients, but heck, 30 to 50% of people with type 1 diabetes relapse, whereas if you have hypertension, 50 to 70% of those relapse, and those with asthma, 50 or 70% of those will relapse. Drug addiction should be treated like any other chronic illness, with relapse serving as a trigger for renewed intervention. When your clients relapse, you need to renew your intervention, just as you do for clients who relapse with their diabetes, hypertension, and asthma. You look at what you're teaching them, what medications they're using, where you can help them be more compliant, etc. They require substance use requires constant monitoring, treatment, and assistance with lifestyle changes, just like other primary care or chronic illnesses. So why we don't screen and intervene? Why do you think that could be? Well, one of the reasons is a lack of awareness and knowledge about tools for screening, and we'll go over what those are today. Could be discomfort with initiating the discussion about substance use and misuse. How do I bring the topic up? Or the sense of not having enough time for carrying out interventions. As the slideshow video stated early on from Adept, Missouri, patients really are open to discussing their substance use to help their health. In this slide, at the very top, if my daughter asked me how much I drink, I would give an honest answer. Well, 92% agreed or strongly agreed to that. If my drinking is affecting my health, my doctor should advise me to cut down on alcohol. 96% of people agree or strongly agree. And as part of my medical care, my doctor should feel free to ask me how much alcohol I drink. 93% agreed with that statement. Whereas I would be annoyed if my doctor asked me how much alcohol I drank. 86% actually disagreed or strongly disagreed. Or I would be embarrassed if my doctor asked me how much alcohol I drink, 78%. I disagreed or strongly disagreed. It's important that you understand that you have enormous power as a primary care provider. Nurses, above all, are seen as the most trusted health profession. People are expecting you to talk to them about these issues. And as uncomfortable as some of you might be in bringing it up, it's important that you do so. We're going to shift and talk about screening for substance misuse in an outpatient setting. Well, first of all, you're going to have to agree upon what is the size of a standard drink. Now, for some, this picture is amusing, but it really underlines the issue that one drink for you may be a completely different size drink for somebody else. Therefore, it's important that you point out what is the size of a standard drink. On the left, you can see that all of these, whether it's wine, alcohol, or beer, these amounts are equivalent to 14 grams of pure alcohol. So for a glass of wine, 5 ounces of a glass of wine is considered one drink. 1.5 ounces of spirits of 80 proof or 1 jigger is considered one drink. And 12 ounces, a 12-ounce glass of beer or 1 can is considered one drink. We know that craft beers are higher in alcohol content, so they may be more than one drink. And it's important to look on the amount of alcohol per ounce that drink has. For women, this is particularly interesting because many women have shared with us that the 5-ounce glass of wine, that they had no idea that they were actually maybe having 2 glasses in one night of wine when they had a full glass of wine. Therefore, if they had 2 glasses per night, within 7 days in a week, they'd be over the risky limits of 7 drinks per week for a woman. They would be having 14. Therefore, it's important that you're able to point out to your clients what you're talking about when you're talking about the size of a standard drink. Screening patients for substance use in an outpatient setting, it really is the first step of the SBIRT process and determines the severity and risk level of the patient's substance use. The result of that screen allows you as the provider to determine if you need to further assess the patient, if you need to do a brief intervention, and we'll talk about what that is, if you need to refer to treatment as a next step for the patient. The result of a screen might also, I didn't put it on this slide, but it also might be, great, you're not drinking, you're drinking at low levels, great that you're not drinking at a risky level. And that would be all that you'd need to do with that client. We're going to go over again about unhealthy use and how much is too much. Drinking or drugging becomes too much when it causes or raises the risk for alcohol or drug-related problems, and it complicates the management of other health problems. Increased risk for alcohol-related problems occur for, when we talk again about this, men under 65 who drink more than 4 standard drinks a day or more than 14 per week, and women of all ages and men over 65 who drink more than 3 standard drinks a day or more than 7 per week. I repeat this for you again so that you can get this down. This makes sense to you. We know that an individual response to alcohol can vary. However, drinking at lower levels may be problematic depending on many factors, such as age, coexisting conditions, and use of medication. You ask why these drinking limits? Well, we know that per occasion amounts place patients at risk for acute consequences and for developing a tolerance. We know that beyond weekly amount places patients at risk for more chronic medical consequences, such as cancers or liver disease. And epidemiological studies can detect increased amounts for disorders like cirrhosis, beginning at these risky levels. Risky use in special populations. We know that if you are pregnant or trying to conceive, that any alcohol is considered risky or high risk. The limit is 0. Medical conditions or medications that interact with alcohol, any alcohol is considered high risk. For adults over age 65, the risky drinking limits are the same as women, which is greater than 3 a day or 7 a week. But low risk drinking for people over the age of 65 is 1 per day and maximum 2 per day for special occasions. So there are 2 levels of screening. That universal screening that we do with everybody, all adolescent and adult patients, rules out patients who are low or no risk, and should be done in intake or triage. Positive universal screen, on that universal screen will help you have the person proceed with a full or targeted screen. And you provide targeted screens to people, to specific patients. This might be somebody that you move straight to the targeted screen because you can smell alcohol on their breath. If they came into the ER, they had a positive blood alcohol level, these kinds of things. You also provide a targeted screen to all patients who score positive on the universal screen. So the universal screen is very simple. The single question screen. In the past year, how many times have you had, for men, 5 or more drinks on a single occasion, or for women, 4 or more drinks? It says here a day, but it is on a single occasion. In the past year, how many times have you used recreational drugs or prescription drugs other than how they were prescribed by your provider? These are the single question screen for alcohol and drugs. For all adult patients positive on a single question for the alcohol, you do the U.S. audit, alcohol use disorders identification test, or the DAS-10 for those positive on the drug screening, which is the drug abuse screening test. For all adolescent or young adult patients positive on a single question, you do the CRAFT 2.0, which is a screening interview for anybody under age 26. So these are the screening tools we'll be talking to you about today. The U.S. Alcohol Use Identification Test addresses recent alcohol use, alcohol dependent symptoms, and alcohol-related problems. There are 10 questions, self-administered or through an interview. Originally developed, by the World Health Organization. And this is the U.S. version adapted by Center for Disease Control and Prevention. The strengths of this are that it's public domain, it's free, it's validated in multiple settings, including primary care. It's quite brief and flexible. It focuses on recent alcohol use and is consistent with ICD-10 and DSM-5 definitions of alcohol dependence, abuse, and harmful alcohol use. The limitation is that it only screens for alcohol. No, it doesn't screen for drugs. These are the questions on the audit. I'm not going to read these to you, and you can certainly go back and review them. They're very simple and straightforward. And this is the scoring sheet. For those who score, if you're a man under 65 and you score 0 to 7, you are considered a low-risk drinker. And for women, 0 to 6. And as the number gets higher, that number helps that the person becomes an at-risk to moderate use, harmful use, or an alcohol use disorder. By the way, these levels will also help you determine at what point or what intervention you need to implement. Certainly if they're low risk, you tell them, good job, I'm glad you're drinking at a low risk level, or if they're abstinent, that is fine, and you document and that's it. If they're at risk moderate use level, you do, or harmful use, you can do a brief negotiated interview. And if they're alcohol use disorder, you might do a brief negotiated interview and referral to treatment. The DAST, it is a 10-question assessment, self-report or interview of screening questions for risky higher drug use that parallel the MAST, which is another alcohol screening instrument. The strengths are that it's sensitive for risky higher risk drug use, and the weakness is that it doesn't include alcohol use. I wish we had one test for both, but we do not. This is the questionnaire. I'll give you a few minutes just to look at, a few moments I should say, just to look at it. And again, you can go back to your these notes later. And this again is a scoring. The CRAFT is, I'm a child and adolescent provider, therefore I really do like the CRAFT. It's for those who are under 26 years of age, and it has 2 parts to it. This is how we introduce the CRAFT. Please answer these questions honestly. There are a few questions that I ask all my patients. Your answers will be kept confidential. And then this is how you start out. In the past 12 months, you ask about these questions. And if all the answers are no, you ask the car question in Part B. If you answer yes to any of these questions, you need to ask all of the questions in Part B. The first question is, have you ever ridden in a car driven by somebody, including yourself, who is high or been using alcohol or drugs? And then if they had answered yes to any of the previous questions, you ask all of these. And again, the craft scoring instructions. Each yes response in Part B scores 1 point, and a total score of 2 is a positive screen. Total score of 4 or higher indicates a high likelihood of substance use disorder. And again, this just talks about the fact that you have abstinent, low risk, risky use. And we know the highest success rate for treatment is at this level. 50% of health consequences of alcohol begin to occur at this level. But the level of risk also, again, helps you determine the level of your intervention. Severe or dependent, you would refer to treatment. Risky or harmful, you would do a brief intervention and possible brief treatment. Low risk or abstinent, you would do screening and feedback only. For intervention and follow-up, just to repeat, feedback only for those who are abstinent or low-risk patients. Brief intervention is provided to risky use patients. Referral to treatment is provided for all patients needing or wanting more help. And a follow-up you should always do with your patients to reassess and reinforcement of follow-up visits. In outpatient clinics, SBIRT is done annually, and at times other visits, because if you suspect things have changed or your patient is drinking, it's important to redo that. To let you know that for every 100 patients you screen, approximately 80 will be negative on universal screening, 20 will be at risk, 6 will be low risk, 10 will be moderate or high risk, and 4 will likely be dependent. Well, you do a screening, now what do you do? Well, steps in brief intervention is you engage with your patient, you provide them feedback, you build a readiness to change, and you negotiate a plan for change. And this is done through motivational interviewing. The technical therapeutic definition of motivational interviewing is that it's a collaborative, goal-oriented method of communication with a particular attention to the language of change. It is designed to strengthen an individual's motivation for and movement toward a specific goal by eliciting and exploring a person's own arguments for change. Bill Miller is Professor Emeritus at the University of New Mexico. He and Sam Rolnick developed the motivational interviewing as a whole, and he is still around today to revise and improve upon his model. The spirit of MI is a way of being with your patients that is collaborative, evocative, respectful of autonomy, and compassionate. To be frank with you, as a nurse practitioner, or as a nurse myself, I think that MI dovetails beautifully with being a nurse and ways in which we work with other people. This is an example of a brief intervention in an outpatient clinic. This person has already been screened, and the woman here is doing an intervention.
Steve is a 30-year-old male presenting with the chief complaints of insomnia and feeling anxious. Steve's audit score places him in Zone 2, the risky category of use.
Steve, before we're done with our visit today, I was wondering if you'd be willing to take a few minutes to talk about your drinking.
Okay, like what?
Well, you filled out this survey for us today, which was great. Thank you very much. I just wanted to review a couple things on here. I noticed that you said that you drink 2 to 3 times a week, drink 3 or 4 drinks at a time when you do drink, and weekly have more drinks than that. So 6 or more drinks, it says on here. Does that sound realistic?
Yeah, on the weekends.
Okay. I just want to let you know I'm a little bit concerned about your level of drinking. We know that excessive drinking can make problems worse or can actually cause health problems at times. And I was just wondering if you thought about the connection between your drinking and things like the anxiety and the insomnia that you came in with today.
No, I guess I haven't really thought much of it. I don't really think I drink that much in the first place.
Mm-hmm.
So I have a hard time believing that it's causing my anxiety.
Mm-hmm.
In fact, on the nights when I don't drink, I have a harder time going to sleep.
Well, you're not alone. A lot of people think that drinking helps them sleep better. And in reality, drinking might make you fall asleep faster, but it has what's called this rebound effect. And this rebound effect means that you might wake up in the middle of the night or early in the morning and have a hard time falling back asleep.
Well, I guess I do have about 2 a.m. I tend to wake up on the nights I drink too much.
Well, I just wanted to show you this little chart here. For your age as a male, you're drinking more than those at a low risk level. The low risk level for men under 65 is no more than 14 drinks a week and no more than 4 a day. And in this case, a drink is considered 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of distilled spirits. And you're right, you're not drinking as much as some people out there. The way you answered our questions here, you're actually falling in the high-risk category, the risky or hazardous category, category 2.
Geez, no, I didn't think I was that bad.
That's why it's helpful to look at this and give some perspective. On a scale of 1 to 10, what is your readiness to change? 1 being, I don't want to change at all, and 10 is, I really want to change.
I don't know. I mean, this is all news to me. I don't want to do anything to put myself at risk, and I've always thought of myself as a pretty healthy guy. I guess I'd put myself right in the middle at a 5.
Well, that's great. That's halfway there. What kept you from just giving it a 1 or 2, something lower?
Well, I'm training for the marathon, and that's why I'm coming in, is because I need to be able to get my sleep back on track. But I also don't think of myself as a hazardous drinker, and I'm certainly not an alcoholic, so that's why the middle ground, 5.
Okay, well, that's a good place to start. So I heard you say your health is important, and you're getting ready to run a marathon, so you want to be able to do what you can to make that successful. And you also were a little bit surprised that you fell into this risky or hazardous category.
Yes.
Okay, so based on all that information, what are you willing to think about doing to change right now?
Well, I think the natural thing would be to cut back a little on my drinking.
So what would that look like for you?
I guess drink no more than maybe 3 or 4 times a week, and on the weekends, which is when I would drink the most, cut back to no more than 5 or 6 beers.
Okay. Well, sometimes when people are ready to make changes like this, it helps if they write down their goals, gives them a chance to see them in black and white. If you were to look at this little form here and figure out where you want to go with your drinking, what would you put down as your goal?
Doing the math, I guess, no more than 18 drinks a week.
Okay, so that's an improvement. So you're headed in the right direction. I do want to let you know that with 18 drinks a week, you're still falling above this low-level risk category. And it would be my recommendation that at some point you would fall below into this 14 or less a week. But it's an improvement, and it's a great place to start. And I really commend you for your willingness to take a look at this and try to make some improvements.
Thanks.
So I'm hoping that in your appointment next month, we can touch base on this and see how it's going.
Sure.
Okay, good.
Well, that was an example of a brief intervention, or a brief negotiated intervention with utilization of motivational interviewing skills. We're going to go ahead and talk about referral to treatment next. This is a critical aspect of the SBIRT process. We're going to talk about what is treatment. Treatment actually might include counseling and psychosocial rehabilitation services, could include medications, involvement with self-help, such as AA, NA, or Al-Anon, complementary wellness, diet, exercise, and meditation, or a combination of the above. It's important to note that substance use mistreatment is provided within a spectrum of levels of care, often available in multiple treatment settings. That the level of care is often determined by the severity of the illness in the substance use. That you need to find out, do they meet criteria for a substance use disorder? And if they do, what is the severity specifier? Is it mild, moderate, or severe? And are there medical or psychiatric comorbidities? Inpatient treatment, as you know, is reserved for those with more serious illness, moderate, severe, or substance use disorder, or with combination of a comorbidity. We know that referral guidelines for greatest success include a determination if the patient needs medical detox. You need to find out whether there's it's inpatient. We know that there are more outpatient for adults in the state. A non-dependent substance user is usually treated as an outpatient unless there are other risk factors, and that most patients can be successfully served in outpatient treatment. A strong referral to an appropriate treatment provider is really key. When your client is ready for this, you need to make a plan with them. Sit down, write it down, make it specific and short and goal-directed. You or your staff should actively participate in the referral process for this client, and the warmer the referral handoff, the better the outcome. You need to decide how you will interact or communicate with the provider you're referring the client to. Does the provider give you a release of information so that you can communicate with them directly? Do you want to speak to that provider in front of the client so that they can hear what you're telling them? And then you need to confirm your follow-up plan with the client. Are you going to see them weekly until they get into treatment? Something like this. And you need to decide on the ongoing follow-up and support strategies. Maybe his family is available to him. Maybe he has a sponsor that can be of help. It's important to write these down so that the client knows what to expect. This is just a slide speaking to the treatment option services for juveniles in the state. We know that currently there are no detoxes available for juveniles in the state. We know that there is extremely limited options outside of the I-25 corridor as well. However, most RTCs will serve the entire state. And these stars here, we have yellow for residential, purple group home only, intensive outpatient only. We've got 3 of those, and then multiple services are available at the red starred sites. Also, we have treatment options for adult services. There are more options available in the state and in more parts of the state for those adult services. And obviously, then there are none for juveniles. In rural areas, we are aware that they are still underserved. And we're also going to give you handouts so that you guys can have this in your setting that you can refer to in your area or in other areas in the state. One aspect of our grant I'd like to speak to you about is the ESPERT Champion Coaching and Learning Community Program. Carmen Martinez-Tittman, our motivational interviewing network of trainer is putting together a learning community for ESPERT champions. These are an ESPERT trained, enthusiastic person who wishes to increase MI skills and champion this whole ESPERT program in the state. The goal is to support and enhance the sustainability of the ESPERT program in your clinical setting through striving for proficiency of these MI skills. We know that MI skills cannot be learned in 1 or 2 settings. You need, or 2 rounds of training. You really need to have a community that you learn them with. And the how is to participate in this learning community that provides observation and feedback of MI skills on the ground and online with Carmen. I will give you my contact information at the end of this presentation so that you can contact me if you're interested. This is also a slide that just points out that we have here at the University of New Mexico Community Behavioral Health, my division, we provide continuing education on substance abuse and other topics related to mental health and health in general. There are free CEUs attached to them for those of you who already have your license, and they're easy to access. Go to this website and you can get on the listserv so they will announce them to you when they come up. Are you interested in learning more about ESPERT and motivational interviewing? Our grant is able to come out and provide full ESPERT MI training of your staff. We can do consultation or implementation with ESPERT in your clinical setting. We can train basic motivational interviewing skills and provide answers to any questions you may have about our grant, training health profession students and providers. This is the contact information for myself and for Deborah Heath, our program manager. And I just wanted to thank you for your attention today. You've been a great, I hope you've been a great audience. I'm assuming you are. If you're a nurse practitioner student, you're sitting right where I sat many years ago myself. And I want to thank you very much for your today and wish you much success in your program and in using this model.